So the paradigm would appear to be that there is injury. That injury is associated with inflammation. Inflammation causes recruitment of stem cells. If there is a small amount of injury, and they are very, very good stem cells, then there's repair and regeneration. So if we have a small cut, we can repair that very well. But if there's and that repair and regeneration then turns off the inflammation. However, if we have a very large injury, or the stem cells aren't working as well, we have less effective repair, so we have continued inflammation because we don't have effective repair. And that continued inflammation can increase the likelihood for the progression of atherosclerotic disease and also result in scar formation. And again, another challenge with autologous cells is obtaining the cells from the patient. And although it's very straightforward, it does involve a cardiac biopsy, and this may be associated with some risks, particularly in individuals who are older, who have concomitant disease, who have significant left ventricular dysfunction. So the alternative is to get the cells from a donor, and that's called allogeneic stem cells. The advantage here, it's a young, healthy individual. There's ready availability. There's no biopsy risk to the patient. There's no time delay. It's less expensive, and it's scalable. So you don't have to have a cell culture facility at every hospital, every community hospital where you might want to use the stem cells. The potential disadvantages are immune attack on allogeneic cells, and the fact that you may generate antibodies which may preclude further cell administration and or eventual heart transplantation. Another challenge is how to give the cells in the coronary artery or directly inject them into the heart muscle itself. So if we give it into the coronary artery, there's a size limitation for the type of cells which can be used. And there's also a limitation on the number of cells that can be used, because if we use very large cells or a large number of cells, then they may result in blockage and occlusion of the coronary artery. When we give it intracoronary, it also requires coronary artery catheterization, requires an open artery through which to infuse the cells. So if the artery is completely blocked, then we're not able to give the cells into the area which has the scar or the damage. And giving it in the intracoronary artery also requires the cells to migrate outside of the vessel into the heart muscle itself. If we give it directly injecting into the heart muscle, we have the risk of perforation of the heart muscle and also uncertainty regarding the injection site. Because we right now can't use MRI labeled cells in the MRI technique that Dr. Balti described. If we inject it directly into the scar, then that's a very, that area does not have any perfusion, so the cells are going to die if you just inject them directly into the middle of the scar. If you inject them into the completely normal area, then there's not likely to be significant benefits. So we want to try to inject it into the border zone area. And then there's the issue which was discussed before, how long the cells are able to function after we give them. So there's limited retention of cells following any type of administration so far. There's washout of cells if we give it in the vein or the artery. There's dilution of cells. There's immune attack if they're allogeneic. And we're injecting them into a hostile environment. So if we inject them in someone who's had a recent heart attack, there's a lot of inflammation. There are a lot of toxins and apoptotic cell signaling going on at that time. So there's a brief duration for the cells to have a benefit, and there's uncertainty regarding the time of administration. When should we give it after the heart attack? So our present focus is directed to two areas. One is the paracrine hypothesis. And this hypothesis says that there are intrinsic natural repair processes in the heart, but they're overwhelmed in the setting of major injury, and they're incapable of complete repair. So they're okay for normal wear and tear, but not in the setting of a major injury like a heart attack. And that the primary mechanism responsible for the stem cell benefit is not the stem cells themselves becoming new heart muscle and artery cells, but rather soluble factors released by the stem cells, called paracrine factors, which turn on or turn up these intrinsic mechanisms. And the second area which we're working on now, or in the future, will be to try to rejuvenate old stem cells, to try to treat the old stem cells with interventions which may rejuvenate them. So in summary, cardiac dysfunction is widespread. It's associated with significant mortality and significantly impaired quality of life. The treatment options which we have available now are very limited. There's a clinical need for, and there's therapeutic promise of stem cell therapies. And there's significant opportunities for progress. But significant challenges remain, and translation to the clinical setting is just beginning. Safety, which is our primary concern, and efficacy assessments require careful oversight and multidisciplinary collaboration. I'd like to thank you very much, and I'd again be happy to answer any questions which you have. Yes?
Can you say a little bit more of this paracrine hypothesis? So it's not that the stem cells you're putting into the heart are sort of plugging up a hole or something,
Well,
but they release chemicals that then stimulate the repair?
Right, so it's not that they themselves are turning into new heart muscle cells or new blood vessel cells, but that they're releasing factors which turn on intrinsic repair mechanisms, intrinsic stem cells.
So you're talking, well, yeah, the main one is you're looking at ways to rejuvenate old stem cells. Can you say something more about what you're looking at to do that?
Well, there are different factors. So one way may be, for example, to expose them to young stem cells.
Embryonic? Embryonic?
No, we don't use embryonic stem cells. When other scientists have done parabiotic pairing experiments where they hook old and young animals up together, and they do injury to the old animals, the muscle regeneration is poor, but when they hook them up to young animals, the muscle repair is much better. So it seems that the factors released in young models which can turn on older repair mechanisms.
Does that inhibit the repair in the young animals, though?
No. No, it doesn't seem like they're inhibitory substances in the old. It's not that the old is inhibited by something, it's just that the young have more stimulus of something.
So just given the emphasis on the paracrine factors, the factors that these cells are releasing, are you working with gene expression collaborators to try to figure out what in fact those things are, and then maybe you can just move to factors rather than cells?
Right, so there are somewhere between 50 and 100 different factors which are identified so far. So our view is that the cells themselves are the best factories because they get the signals, and so it may be that in day 1 of an infarct you need different factors than you need in day 30 of an infarct, or different amounts of those factors. So although we can identify factors, we don't know when to give them and how much to give them and which ones exactly to give them yet.
And just to follow, are there kind of epigenetic factors that are helping with the timing of these things?
So we don't know, but there are probably different signals being sent out from the damaged, repairing, scarring area, saying, send this thing over here now.
My understanding from wound healing is that once scarring occurs, it's relatively inert tissue and it's very difficult to remodel it. Does that carry through in your work? And would it suggest, timing of intervention is crucial?
Yes, I think the timing is very important, and ideally we would want to give it as soon as possible to try to decrease scar formation and increase regeneration. In our models where we've seen decrease in scar, it's most prominent when we look at it as the percent of the total left ventricle, so that the decrease in the proportion of the scar we feel is most likely due to an increase in generation of healthy muscle.
And then as a follow-up, in looking at possible allogeneic, is this something where it might be possible to have a variety of broad HLA type matches on the shelf, or
Yes,
is it one? Okay.
it's possible.
Is that the route that you think?
Well, what right now, what we're thinking of is allogeneic MSCs, and the mesenchymal stem cells are sort of immunoprivileged because they have this potent anti-inflammatory influence. So we're not doing that right now, but it's possible that we would do that in the future. Yes, sir.
So the parabiotic experiments would suggest that the responding young cells don't necessarily need to be at the site of injury.
Yes, sir. Right. So we think that the signals, that whether they're cytokines or interleukins or something, are coming from the site of injury to the bone marrow or to sites which are producing stem cells and causing the release of these factors. Yes, they don't have to be at the site of
So
injury.
it may be that you won't eventually need to inject the heart muscle itself to drive that.
It perturbs me that the two clinical trials you described are really different, especially in terms of the timing of the intervention, so that although you may have gotten really valuable safety feedback from the two trials, you could have really confounded any information in efficacy if with the second trial, because it was so late. It was well, as you said, well after the patients had experienced a cardiac event. So they may have been well past an opportune moment to intervene.
True. We did not expect to combine the results of the studies, and so they were very different, not only in timing, as you point out, but also in terms of the route of injection, route of administration, and the types of cells which we use.
But the second one made it seem as if there was no efficacy at all, right?
There was no difference between the two cell types, but so there wasn't a placebo. Both groups were better than the baseline.
Oh, they were?
Yeah, they were better than the baseline, but they were not different from each other, from one another.
As sort of a follow-up to that, did you choose the second patient population in part because of regulatory concerns that did not allow initial first use in an earlier patient population?
No.
Okay, terrific. Thank you very much for that.